আমরা কি স্টার্ট করব?
Just after 10 seconds, you can start your talk.
Okay.
Tushar, countdown শুরু করো।
Yes, sir.
Sir, we are live now. You can start.
Assalamu alaikum and good evening, dear physicians. Today is our 49th session, lecture session, which is ECG Fun Fest, organized by ECG Study Group. And today we have among us a famous physician from USA, Dr. Chowdhury Ahsan sir, and Dr. Rafique Ahmed sir. Before starting the program, I'd like to request Professor Abdul Chowdhury sir to say a few words regarding our presenters today. Wadud sir.
Assalamu alaikum and good evening to everybody. Actually, the audience who has been joining with us regularly, they know Professor Chowdhury Ahsan very well, a very jolly and very well-informed person who can present anything related to cardiology in such a way you will get knowledge and fun put together, and that's very rare. Today we are again going to glimpse that rare character in a very academic person who can be very relatable in a very simple way. Professor Chowdhury Ahsan, we are waiting for your fun fest.
Wadud, thank you. That was a nice introduction. Can you see my slides?
No.
Not
Okay.
yet. Not yet.
You can share the screen. Can you screen share?
Share. You don't see my screen, right?
No, sir.
No.
Hafiz, you can on the bottom panel. There's a share screen. Then you can choose which screen to share.
No, but my slide is not. I don't see that in this. I don't see. This is not the one that I wanted to show. Let me see this.
Initially, you showed some slides.
Yeah, it was good, but then I was trying to send something to Saya. So let me see. You don't see now? No?
No. Sir, you can close the PowerPoint and start it again. Then you can share your screen. It might work. While you are wanting to share, you can close it first, and then you can.
Okay, so yes. Close everything.
Yes.
Okay, I'm closing everything.
Yes. Then, sir, you can open the PowerPoint.
Okay, so let me share.
And then you can choose the share screen.
So now I'll have to go to the okay. So if I
Assalamu alaikum. Wa alaikum assalam.
Okay, I'm going to going off and then coming back, okay?
Okay.
Give me 1 second. Sometimes that is better.
Okay, sir.
Okay.
Or you can email to me, I can share for you.
And Saya, you have the slide deck, right?
Yes, sir. Will I share now then?
Yeah, yeah.
Okay. Okay.
Why not
You
you
can
do
do
that?
that, yeah.
I'm joining from my phone.
Okay.
Sir, can you see the screen?
Yes. It is visible.
Okay.
Prepare the poll.
Sir, poll is ready whenever you all want to. We can start.
Okay.
Sir, should I stop the screen share now?
Officer is still not in the screen. Has not joined.
Yes, I think I might stop when sir
keep
will
it
come.
here.
Okay.
You
Okay.
keep it
Okay.
here.
Okay.
Once you join.
All right.
So I'm back.
Yeah, we can see it now. We can
So
see it.
Wadud, I
Yes.
completely screwed up this morning. I left my, that's why I was not talking, because as a contingency, I sent this slide deck to Saya, So because that's why it was struggle. So anyway, can everybody see this?
Yeah, we can see it.
Yes, sir. So once you say, then we'll start poll.
Yeah, we can go for the poll.
Okay,
No,
sir,
it
for how
just
many seconds? 30?
Describe the scenario.
Yes, sir.
So this is a common thing that we are all the time get referral for, right?
Yeah, this type of patient. Yeah. So the scenario is 83-year-old female, hypertensive COPD, had a mechanical fall, and before the hip fracture surgery, the pre-op showed this ECG. Echo was normal.
Actually, echo
No.
No,
was
sir. Echo, there was some gradient.
Aortic
and,
valve gradient,
Yes, sir.
not
echo,
marked.
there was a mean gradient 30,
30.
aortic valve area calculated and reported as 1, chest X-ray, nothing abnormal shown, BNP normal, vitals good, pulse ox 95%.
Sir, should we start the poll now?
Yeah, sure.
For 30 seconds?
Make it 20 seconds, just enough.
So
Okay, sir.
everyone please vote. And there is nothing right and wrong in terms of, nobody's watching. So, but it will give us some idea that what we need to do in future to bring everybody to this speed. Please vote. Okay. So 43% said proceed with surgery. Can anyone in that group say why you said that?
Please raise your hand so that we can
Anyone?
let you speak.
Any faculty to have a comment?
I can comment on that. Okay.
Yeah.
I think when you look at pre-op evaluation, as you know, that you have to look at several factors, right? What is the surgery? How much surgical risk the patient himself from the cardiac condition or other condition, and what kind of surgery is going to have? What's the risk of that surgery itself? And also, third component we need to keep in mind: what's the functional status of the patient? And as I say, so that's the way we need to think about. The patient has hypertension, COPD, really no other comorbidities except for probably moderate aortic stenosis. It's not severe, so that's not a contraindication for surgery. Question right now, we don't know exactly what is functional status. That's going to determine, whether you need to go directly for surgery or do some testing for surgery first. On the other hand, you have to keep in mind the patient probably needs surgery because of hip fracture, and it has to be done sooner the better if you can do it. Because if you don't do it, the patient will not be able to walk, and that will increase his comorbidities and further problem. So that's the thing. These are the things you need to keep in mind before making the decision.
So if that is the case, where should we go with this patient? With the
And another
sinus
thing is that,
bundle?
Hafiz bhai, can I add something?
Yeah.
Look at this. The history doesn't suggest the patient needed any added oxygen. Partial pressure oxygen quite all right, 95%. And the BNP is quite good. In a 83-year-old, BNP, if it is not more than at least 1500, I would not be that much worried. And it's only 200. So patient is very stable, no cardiac issue, active. So, and another thing is that we can go for this surgery with the epidural anesthesia.
Yes.
You don't need to have general anesthesia also. So that's also helpful.
So those who wrote proceed with surgery, anyone from that group has any comment?
Dr. Hafiz, can I ask a question, please?
Yeah.
Can you explain actually what do you mean by the mechanical fall, and what is the explanation of the non-progression of the ROA in ECG?
So first of all,
left bundle branch block.
Left bundle branch block. But the mechanical fall means in the history that there is no loss of consciousness, no syncope. So patient did not tipped over and then fell, and then there was no suggestion. History taking is very important, that there is no loss of consciousness. So we are trying to say that this is an asymptomatic aortic stenosis which falls into the moderate severity, left bundle, and the patient has no decompensation. When it is a emergency surgery or urgent surgery or time-sensitive surgery, which is hip surgery, then there is a significant implication that hip surgery can result in, if we don't do hip surgery, increased mortality. So we do everything to get and expedite the hip surgery in a timely fashion, almost like an urgent case. Unless there is a decompensation cardiovascular, such as arrhythmic decompensation, heart failure decompensation, patient in the middle of an MI, we don't need to delay the surgery, even with severe AS. For convenience, I made it moderate, but even in severe AS with asymptomatic patient, it is still okay to go for this. Now the RCRI, the revised cardiac risk index, that was done by a fellow in Boston a long time ago, but that was in the setting of elective surgery. You can assess the risk profile, but in emergency surgery, urgent surgery, unless there is decompensation, there is no holdup. We need to be clear about that. Let me go to the next case. Any comment? Otherwise, I'll go to the next case.
Now,
I
actually,
think that's a very good description.
Dr. Hafiz, I think
Yeah.
two things should be considered as a cause of the mechanical fall. As one is the aortic valve, and another, the patient with such type of ECG has a got a chance of the paroxysmal AV block. We cannot totally exclude the chance of paroxysmal AV block in this ECG. The patient with
Right. So, go ahead.
One comment I'd like to make. That's the reason he put it mechanical fall, because it's an accidental fall. So we know that he probably tripped over. So that's a mechanical fall. And on the other hand, only question that might arise here that a lot of people are thinking about version 2B because of left bundle branch block. That's the only thing that you might have, thinking about whether there's an underlying coronary artery disease that caused, or there's an old ECG to compare, that would be helpful. But in this situation, as Dr. Hafiz mentioned very well, urgency of the surgery and moderate aortic stenosis, even severe aortic stenosis, is not a contraindication. And Dr. Wadud clearly mentioned that if a spinal anesthesia could be achievable, that's the best option for these patients. Because as soon as you can get the surgery done, the patient will be functional, his comorbidity would be much less, and a good chance of recovery for him.
I usually do the echo.
Yeah, if he's symptomatic, like any chest pain tightness, yes.
Yeah, I usually negotiate with our anesthesiologist that, yeah, we can give you an echo. You can decide what type of anesthesia you are going to do, what kind of precautions you are going to take. But the surgery is not prohibitive. So, in the assessment of this kind of patients, I write that the risk is moderate or risk is high. In the current guidelines, risk is low or high, they call it. And then you say that patient understands. And then importantly, we mention that the patient is hemodynamically, rhythm-wise, heart failure-wise is stable. And the surgery is not prohibitive. Only time surgery is prohibitive when there is a decompensation. Then you optimize first and then proceed. Okay, so next one. Oh, I forgot to flip this because I wanted to keep this for Rafique bhai. This is a 62-year-old. What is the rhythm? The options are in the following. Line. Okay, you got it.
But we don't see the options though. But anyway, we see that on the picture.
Options are in the lower panel. AFib with left bundle below the EKG. AFib with left bundle, AFib and V paste, slow VT, and hyperkalemia given patient's presentation. Presentation with little fatigue, shortness of breath.
Hafiz bhai, can I have a request?
Yeah.
Whenever we are talking AFib, I would like to say atrial fibrillation, because many youngsters are there who may not be understand readily.
Okay.
And V paste, I would say ventricle paste.
Okay, thank you. Atrial fibrillation with left bundle, atrial fibrillation and ventricular paste, slow ventricular tachycardia, hyperkalemia with given the patient's presentation, fatigue and shortness of breath. Wow. Wadud, we have a problem. You want to
only a few people actually answer.
You want to take it?
Yes.
Atahar bhai, would you please give some comment?
Yes, this is a very ugly looking ECG, what we call actually the ugly looking ECG. But from the rhythm strip, we can see the ventricular complexes are irregular, totally irregular. There is no P wave. The QRSs are the LVB morphology. and we can see the first beat, then second beat, there is a small spike before the second beat. The third beat does not, fourth beat no, but again on the sixth beat, there is a small spike. Seventh beat, there is a small spike. Seventh, then this was not, but finally there. So, and most of the beats are preceded by the small spike that indicate the presence of the pacemaker. Some of the beats are not. And the irregularity is maybe due to the atrial fibrillation. So this is the ventricular spaced rhythm with atrial fibrillation. This is my first diagnosis. And because of the presence of the spike, ventricular tachycardia is excluded. And as a cause of the atrial fibrillation or something, hyperkalemia cannot be totally excluded. So basically, this is the atrial fibrillation with ventricular paced rhythm.
You know, I'm telling the audience that if you can listen to Atahar Bhai as like a solid cardiology student, he was answering the question. So I totally agree with you. And the next step in the management that this is AFib with fixed ventricular pace, and long term we have concern that these patients may go into heart failure. And therefore you need to be addressing this issue, that whether you want this patient to be all the time paced. So I will stop there because I thought Rafique Bhai will be here and go for further management issue. But clearly you can see the V-paced, irregular, and then this is atrial fibrillation with ventricular paced rhythm. So let's go to the next one.
Hafiz Bhai, can I make a comment?
No, I have, yeah. Dr. Wadud.
Whenever we get an LBBB pattern where there is a broad, wide QRS complex in one in AVL, but in V5, V6, there is no such wide complex. You should always consider, is this paced rhythm? And look at the beginning of the QRS complex, you will always get a small spike.
Another question I have, when you looked at that, definitely V5, V6, we don't see the true V-paced rhythm from the right ventricle. But whether he has bi-V device, that's another concern. Okay, and depending on the synchronicity of that, that could be, what level of if the patient has third lead in the coronary sinus somewhere, that's putting that type of complex there. That's just another concern I have. Third thing, that if you see that like in 1, 2, 3, third row, we see that just before the last beat, we see some complex. We don't see the clear-cut V spike, paced spike. We do not see that. Or there's any underlying ectopic beat going on there. That's another concern. Okay, so I would not rule out whether the patient has bi-V device here with underlying atrial fibrillation. I'm not Dr. Atahar Bhai, you can comment on that, because I don't see the complex that you used to see on the V-paced rhythm from RV only.
One participant is asking why the AFib and the paced rhythm is irregular.
Achha. So I have got that is explanation about the two questions of Dr. Azizul Haq. First one, possibility of the bi-V pacing, that is the CRT. This is unlikely, as because the QRS complexes are wide and V1 is LBB morphology. This is unusual, and there should be a Q wave in lead 1 and AVL. So from the ECG, it is unlikely this patient has got the bi-V, that is the CRT. This ECG indicates only the RV paced rhythm. So bi-V is unlikely from this ECG. And secondly, the third row, the beat before the last beat, there is no spike. Yes, sometimes this may happen because the possibilities of this beat is maybe this is a ectopic beat, or this may be a partially fused beat. That is the fusion beat. Mm-hmm. So the presence of the fusion beat or the presence of the ectopic beat sometimes may not be, that at the time the spike may not be totally clearly visible. So the differential diagnosis of this beat is maybe a paced beat, that is a fused beat, or it may be an ectopic beat. So this is my explanation about the C8 and this bit. And what are the participants' questions, Habib bhai?
The why it is irregularly paced. Like, so the RR interval paced rhythm is also irregular with the AFib.
So actually, 1, 2, 3, 4, 5. If we consider the bit number 5, 6, 7, and 8, these 4 bits are regular. At this time, that is 6, 7, 8. These 4 bits are regular. That is the regularly ventricular pitch. When there is an ectopic bit at that time, that is what is actually Dr. Azulok says. So explanation of this irregularities may be due to the ventricular ectopics. That ectopics are sensed, the timing cycle is reset, and again there is an irregularity. So irregularity is because of the ectopic bit. When there is no ectopic, the pacing is at the regular interval. That is 1, 2, 3, 4, 5, 6, 7, 8, and 9. These 4 bits are totally regular at the rate of the spike.
I still don't have the explanation to V5, V6, why this QRS complex will be downwards. If it's V pace, it should be upwards. So either some other problem going on underlying that's making it wide. Electrolyte problem I cannot rule out.
No. Which one actually, Dr. Azulok? That is the
V5, V6, like, you know, when you pace from the right ventricle, we expect that upright.
No, actually, this was the explanation of Dr. Abdul Wadud Chowdhury. Abdul Wadud Chowdhury. This is the point by which we can actually differentiate the paced rhythm from the true RVB. That is a true LVB versus paced LVB. That is the one there is a paced LVB due to the paced rhythm. The QRS, that is the LVB, that is the V5 and V6 may not have the tall R wave.
Right.
But the true LVB, the R wave should be taller in case of the V5. So this is the LVB due to the paced rhythm. This was the actual explanation by the Wadud Chowdhury. Chowdhury?
You have already said that.
Yeah.
And then Adit Bhai was asking, that's the valid question we should be looking for. And in that case, we have to analyze the pacemaker, where it's going wrong.
And by the way, the pacemaker function is okay. But the reason I showed this because this is not a by V paced. So this is so much RV paced. So long term, it may not be the best thing for the patient. So think about this, what you do for the management. So let's go to the next one.
I wish I could see the chest X-ray of this patient.
Yeah.
Was that?
Chest X-ray on this patient.
Oh, by the way, Aziz Bhai, if this patient had by V paced, the by V part is not working because
that is correct. That is correct. Yeah.
Because if it is by V, then QR is narrow. In a by V pace, if the QR is still 140, 160 milliseconds, then the by V is not optimal. So we need to address that.
I agree with that.
Yeah,
I agree with that.
So next one is 55-year-old presenting for donor surgery. She wants to give the kidney for someone who is waiting for kidney transplant. And they did this EKG, and EKG for HIPAA reason, I can't show you the EKG diagnosis. They said old inferior MI. And this is the EKG. And they are asking you just 15 minutes before the surgery. And the transplant surgeon called me, what the heck? Do I need to cancel this surgery or what do you want to do? So, and this is the EKG. And I gave you this option because we can play safe. We can cancel the surgery. We can evaluate the patient, get repeat EKG with a special instruction. We can evaluate the patient, get repeat EKG, get a special instruction, and do an transthoracic echo, hold surgery until then, or we can do proceed surgery and then cancel surgery for today, get a stress test, then decide if we should perform the surgery after the result.
Review poll, please.
Yes, sir. Started the poll.
And I just wanted to give you the scenario again, that the transplant team is ready and they are waiting for this donor kidney in another room. And suddenly this EKG and the anesthesia raised this issue. And our echo is available. Any test you want is available. Wow. So I love this because this is the reason I gave the question. Okay, so, so what we actually wanted to show you that this is the Q wave in the inferior lead. That is the question. Patient is otherwise asymptomatic. Mm-hmm. So not from the faculty, but anyone from the participant, you want to take it? Or any faculty who is not faculty, but who is not in the panel or not talking, you know, because we all are talking all the time. I want to hear that anyone want to take a lead.
Dr. Chowdhury, will you talk about it? Or Dr. Anis, one of you? Chowdhury Anis, do you want to talk about it?
Okay.
Sir, sorry, I just joined. I was a bit busy otherwise. Just seeing the ECG. Actually, I don't know what is the question. Would you please repeat, sir?
So we see the Q wave in the inferior lead, and the anesthesia raised this question that this is old inferior MI because the EKG read that way. And they are concerned that before the surgery, the patient is a donor. So should we proceed with the surgery, or we cancel, or we do something to assure that the surgery for the donor will go well? Or do we need to do some tests? Or what do you think about this Q wave?
Sir, thank you, sir. Sir, the ECG shows Q wave in lead 2, 3 AVF, but this Q wave wide is, I think, not one small square. It is less than one small square. So it carries not significant impact. I think it may not be a case of old inferior MI. And rather, if we think evaluation before non-cardiac surgery, we should consider the patient's functional status. If patient does not have any symptom or functional status is good, then this ECG will not defer the surgery for this ECG changes.
So agree. So let me tell you this scenario that the transplant surgeon, they're very aggressive. He said, "Are you sure? Because I don't want to cause harm to the donor. So can we do anything?" So next slide. Can you go to the next?
Next slide. Yeah.
Okay, so look at the EKG now. Does it help you?
Very much.
Same patient.
Was it taken in deep inspiration?
Yeah, taken by deep inspiration. Exactly.
So
that's the thing we should always.
Yeah.
And
so the transplant surgeon was not buying the fellows thing. So I went there. I just told them to do a repeat EKG with deep inspiration. Q wave disappeared almost. And he thought I was a genius. So next case, please. Okay, so this is a 59-year-old with COVID. 22nd of July, he was COVID positive. And then he got intubated and then he's still struggling. And then got ARDS, you can see August 4th, earlier this month. Patient was weaned down to minimal vent setting, and then attempted to be extubated when he became rapidly hypotensive and tachycardic. Next slide. So COVID, almost like 2 weeks, and then this EKG. And this EKG, I let you see. By the way, this is sinus tachycardia. And then you can figure out the ST changes in your own mind, because that is important, that ST changes whatever way you see. Next slide. I'm rushing a little bit because I want to go through the cases. And then question is, this is now STEMI, and you give pharmacoinvasive approach. I'm telling you what the team thought from the referring physician. I'm not telling you what I think. I'm telling you what the team thought. So STEMI, and then should do pharmacoinvasive, or STEMI, give lytics and observe in our own hospital, in their own hospital, and see heparin and transfer. The PCI hospital, which is us, is less than 2 hours, and the patient should go to the cath lab. And then D, aspirin, heparin, and evaluate by echo and imaging studies. And this patient has COVID, avoid PCI and give lytics. There is no right and wrong answer, I'll tell you. Actually, there is right and wrong answer. There is right and wrong answer. I think by now we should be good enough. But anyway, what is the answer? What is your thought? Okay. So
I think Ajam has shown some cases which raise these questions.
Perfect. I don't know, Azum is here. Azum, you want to comment? So let me tell you what they did. They gave lytics, anyone, and then transferred to us. Anyone would agree or disagree with that?
At present situation, I would disagree.
Okay, then what is your thought?
Because the patient have ST elevation only one AVR and V1. And the widespread ST depression suggesting probable left main disease. But in a COVID situation, that's a very problematic thing. You cannot be sure.
Okay, go to next slide, please. So I was furious with my fellow. I cannot take care of the attending. I said, why the hell you did not do an echo at bedside? And the fellow says, Dr. Ahsan, I did the echo. I said, show me the echo. Can you play it? Ah, wait.
And don't go to that.
Go back, play the echo. Okay, so that's okay. So I tell you this story because don't play anymore. Don't play anymore. So the echo showed LV function normal, and the RV is little dilated and RV not normal, and RV hypokinetic. So if you see that, will you give lytics?
And that's suggestive pulmonary embolism, acute.
Okay, yeah. So it can be pulmonary embolism, right? That is very important. So and then we did but the referring physician is a cardiologist and was thinking that I am actually adamant and arrogant not to do cath. So I said, what the heck, I'll do cath. It takes me 3 seconds. So I did the cath. Show me the cath.
Ahsan, I'd like to see the echo. Are they moving picture there? Video of the echoes?
Yeah.
Please go back. Go back.
Yeah, we really didn't see that well.
You're going forward. You go back.
Go back.
Go back.
Aro aage.
More. Yes.
Okay, yeah. Can you play that?
Play.
Click on the image. This one. Left one.
RV is dilated. We can see it.
Okay, play that. Play. Good. Now the other one. Play this one. Yeah, beautiful.
Yeah, okay, we see it. Okay, thank you.
Yeah. So, okay, next. 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 Okay. Next. 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 Yeah. Next. 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 Okay, good. So, okay, go back. Thank you. Thank you. One. Okay. So at that point, what do you think? What was the diagnosis? Acute PE, STEMI, ARDS, septic shock. Why you are asking this question?
You can poll it.
Okay. So, not bad, huh?
Good.
Okay, next one, quick. So, a say 62-year-old with the COVID positive,
Hafiz bhai,
hypertension,
just-
diabetes.
Hafiz bhai,
Yeah.
in the previous case, please give a little bit of explanation why you should not have gone for lytics right away. That will be very helpful for the young students.
Okay, so the lytics part, I was not unhappy knowing the answer that the fellow gave, because when I heard this, the issue was that it's STEMI. I said, this is not a STEMI. This is acute PE or severe acidosis hypoxia. That can give you the picture. Now with the echo, with RV dilatation, and then acute hypoxia, and then you give lytics for that reason, then it is okay, and probably was good. But you get the diagnosis right. There may be situation that in this case, for example, the platelets is 20, and then patient is already struggling renal failure and also bleeding. And then you are thinking STEMI and telling me to go to the cath lab, then you are just twisting my arms and blaming me. And then writing in the chart that patient died of MI, but that's not the case. And there are many other issues. For example, this may be that RV, if the RV is good and not dilated, not hypokinetic, this can be also explained by hypoxia ARDS and not necessarily because of the PE. But in this case, in totality of the information, it is reasonable to think the patient is acute PE, not a STEMI. This is like a STEMI mimic. Okay, next case.
I think little bit discussion that very important to really do bedside echo this situation, because they had clarified right away that there's RV dilatation and LV function is fine. So that would be important. And clinical factors also important, that what's the blood pressure, or the patient is hypotensive and RV is strained, then it's concerned about lytics. Otherwise, if patient is hemodynamically stable, then maybe just aspirin, heparin is fine. And also another point I'd like to make, what is the platelet counts? The platelet counts are low, then you're limited to everything. If it's 20,000 platelet count, you're limited to everything. Okay.
Yeah. So you need to pay attention to all those. Thank you, Asif. Next one. So 62-year-old COVID positive obese and presented with history of chest pain and the severe burning chest pain going from throat all the way down to our stomach. Next. Recent stress test about a year ago. So this is the EKG. This is the EKG. So what do you think the EKG is? Sinus rhythm, intermittent junctional beat, sinus rhythm and ischemic changes. And the diagnosis is LAD disease or sinus rhythm, ischemic changes, junctional beat. I don't know what it is. I will call for a STEMI activation anyway. So these are like downsloping ST changes, could signify ischemia, but we cannot localize the territory because ST segment depression not necessarily correlate with the area, with the territory. And there is some occasional junctional beat. And this is in the hospital. And the pole is out. Okay, so we are divided here. Divided that majority. I want to please vote. The number is falling, you know. Sinus rhythm and intermittent junctional beats, and then ischemic changes, right? So sinus rhythm, ischemic changes, junctional beats, probably the right answer. But interestingly, the next EKG, go to the next. Next. Okay, so this is, I call it a confusing EKG. This was specifically for Rafique bhai. This patient 10 minutes later has this EKG. There is now right bundle, and then what are the options? I will call a STEMI activation now, number 4, or right bundle, right axis deviation, and PVC, complete heart block, and then high-grade AV block.
So should I go for poll? So should I start the poll?
Yeah, you can start the poll. But any comment from the faculty? This is going to be a confusing, because I wanted to take this patient to the cath lab, you know, because this is the ongoing pain, dynamic EKG change. Should I put a temporary wire?
Let us see the answer first.
Okay.
It's very interesting.
Very. Wadud, I enjoyed so much with this EKG because the reason I fooled my third-year fellow, which is difficult to fool the third-year fellow. Oh, good. Okay. So if you look at the lower panel, it is actually sinus rhythm, and then these extra bits are mimicking like.
Can I say something?
Yeah. Yeah.
In the lower panel, in the rhythm strip, the smaller QRS complexes has
P wave.
P waves looking normal P wave like, but the taller QRS complexes has inverted P waves specifying in each of these taller narrow complex QRS.
Jamil bhai, brilliant observation. Brilliant observation.
That's in front of every QRS complex.
So it seems that it's atrial ectopics.
Yes. So because of that, I did not put a temporary wire. Next one. Next. Okay. So this is the, can you play it? This is the left side. Go to the next. Next, 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 next. Okay, stay there, plate. So this patient had a high grade right. Okay, so pretty simple baby stuff. Next. next, so next, next, so next, next. Okay, nice result. Wait, okay, next. RCA coronary flow is good. Next, next, next. My fellow put a lot of clips here. Next, next. Nice result. Next. Okay, so almost like 18 hours later, she deteriorated. She developed this EKG now. And what do you do? Should we do a chest X-ray, look for pulmonary edema, worsening of the COVID, acute ischemic MR, do an echo, CT non-contrast, look for COVID, all of the above, none of the above, patient has acute PE. This is a very interesting differential I gave you because patient hypoxic acidotic. And so Wadud, do you think it is interesting, right?
But a real life scenario is always confusing.
Yeah. So we did chest X-ray, we did echo, we did all of the above actually.
You have to.
The reason I did the stat echo because I did N95 mask and also double mask and listen to the patient. And in the back, I hear mitral regurg.
Yeah.
So I did the echo and then I see severe MR. Okay, so not bad. Everybody is on board. So we see MR and the LV function is actually pretty bad, about 25%. So next, I don't know whether we have the echo. Next.
Ripu next.
Okay, so, and after that, at this point, I told the ID that this is so much. So we give steroid and tocilizumab, diuresis, and then do all that. Next. And then she was sent home. And yesterday, after about a week in home, she came back and the troponin was 900. She came in for non-specific leg pain and then also some tingling numbness in the hand. And then troponin was 900, meaning 0.9, and they wanted to admit the patient. This troponin was 86,000, meaning 86. And I said, no need of admission. We sent her home from the ER. So this is a complicated case, but this is a COVID patient that has an ischemic episode, MR ischemic. There was no mechanical mitral valve, pap muscle rupture or chordae tendineae rupture. With the support, diuresis, and ischemia gone, hypoxia better. We got this ischemic MR better, but the EF was bad. We gave tocilizumab. I did not wait, but LV before discharge was about 40–45%, which is remarkable. And the patient is doing fine. Next one, quick.
One question, Dr. Hassan. What does the echo look like before the cath?
When we brought the patient down, this was inferior hypokinesis and mild MR or maybe trace MR, but that is bedside. Yeah. And then patient was in the cath table was doing fine and never had any frothy sputum or anything. It all happened after the cath, like 18 hours after the cath.
Hafiz bhai, do you think that's due to clot microvascular dysfunction?
Yeah.
Related to posterior medial peptide muscle.
Yeah, absolutely. And then ischemic MR, and if it wide open, sometimes you need to buy time. And I was ready to put a balloon pump and if needed, an impeller, but usually balloon pump may be okay. Although in the European guidelines, what is your question? If it is unloading, then balloon pump is not the unloading tool. It is the impeller. But in the ischemic area, then you still, I think there is a role. And it sometimes does help. And it is much easier to put it in. 69-year-old with fatigue and shortness of breath. This is old EKG. Can you show the next EKG? And this is new EKG. So question is it old EKG? Can you go back and forth?
Repeat. No. Previous one. Go back.
Back.
Repeat, go back. Go back.
All my
Go back.
mysteries.
Back, not forward. Back. And this one.
It
Back,
was not
back.
working, sir.
Yes,
Sorry.
yes, this one.
Back. One back.
Sir,
That's
this one, the
probably
old.
That's first one, yeah.
Yeah,
this is the
this
first
is old
one.
EKG. This is old EKG, left bundle, and now the patient coming with shortness of breath and fatigue. And then show the new EKG now, please.
Next one. Yeah, this one.
So should we call acute ST elevation MI? Left bundle. Now we suspect hyperkalemia. Stat echo given the changes and clinical presentation. First of all, we all agree that there is a change.
Yeah.
More wide complex.
So the question is left bundle. So left bundle, nothing can be done. So B is that we cannot make any inference. I think we can make still inference in the patient who had old EKG, because the old EKG can change, and change is important. You still can look at the Garbosa criteria, and also you can look at the change, whether there is any hyperkalemia or not. This QRS was wider than before, and the patient had hyperkalemia. Anyone to make any comment on this?
As Rafique sir always said, whenever you see very bizarre looking ECG, always think of what is the pH level and what is the electrolyte level.
Yeah, absolutely.
Hafiz bhai, can I say something?
Yeah.
In V6 and lead standard 1, is there some spikes, pacing spikes, very small at the beginning of the QRS complex?
No, there is no pacemaker.
Okay, thank you.
Yeah, and then we did the, as Wadud mentioned, that we did the
Dr. Hafiz,
ABG electrolytes. Yeah.
Hafiz, can I make a comment?
Yeah.
Actually, this ECG is more consistent with hyperkalemia than acute MI.
Correct. And my question is, if you are in doubt, then you can also do the ABG, the arterial blood gas, potassium level, and also you can put an echo probe and then see the wall motion, because a new left bundle will be a huge issue in terms of, if you think about it, if it is transmural MI, LV function will not be hyperdynamic. So our fellow did the echo, and this is the thing. Patient is like lethargic, maybe dehydrated, and then hyperdynamic. I have not seen a LV hyperdynamic in acute MI. Exception is acute pap muscle rupture. Then you can see LV squeezing good, but there is a pap muscle rupture. So when you see hyperdynamic LV, no MR, then you can close your eyes and say, this is not a STEMI. So next one, please.
And also slight peaking of T waves and also a PR widening also there. So that also can, I think, tell you about electrolyte problems. So
yeah, and this one was definitely for Rafique Bhai. The last two, I don't know where he is. The 87-year-old with past medical history of atrial fibrillation, and she's from Mexico, visiting United States, taking apixaban for prevention of non-valvular atrial fibrillation related stroke prevention, and has a pacemaker, and then fell, had a subdural hematoma, and came to the hospital and was going for a repeat CT head, and then came from the CT scanner and then developed this. And next.
This
in
is
the
prolonged
floor,
QT.
Next, and in the floor, they picked up all this rhythm, which I collected for you. And then next. Okay. And then next. So after looking at this, before the round, I started feeling faint. Next. And then this happened. So the question is, next. Next?
Net argument was only.
Oh, they did not. Okay, go to previous.
The second line is the most important thing.
So,
patient is held
so the patient was getting held on. And so you talk about iatrogenic. This is total of 9 milligram Haldol given. I think somebody was desperate to produce this until it starts, So they gave Haldol, and the magnesium was low. So my question is that it luckily stopped. Magnesium given, we did not give any more Haldol, but what else could be done for not this happening again?
I think the main concern is we have to think about is a prolonged QT going on with the medication and the event and CNS event that happened.
Show me the next.
What is Haldol?
Haloperidol.
Haloperidol.
Okay.
So for that QT prolonged, okay, this is the EKG I got. You want to calculate the QT? Asif.
And we could see a very interesting phenomenon. Look at the first ECG when it started, a rhythm stream. Yeah. You see a PV, like a pace beat, R1T phenomenon, one extra beat that prolonged the QT, and then R1T came on and started the torsade. So that's classic, that with the sotalol and other, we see the mechanism when the bradycardia happens, and you use sotalol, and then that kind of arrhythmia can initiate. Yeah. So we see the similar phenomenon of the prolonged QT and R1T phenomenon that initiated that. And definitely anti-tachycardia pacing could be done. As for example, the patient has pacemaker, you can increase the rate. Yeah. That you could probably have terminated that. Third, make sure magnesium should be given first. Okay.
Yeah. So this is interesting. Yeah.
What was the age of the patient?
I think I mentioned this, 80 something. She's a visitor from Mexico. So now the next question will be.
Do you know why I'm asking this question?
Yeah.
The patient is 80 plus something, but he has survived that long. He may not have QT prolongation as a congenital problem that may be acquired.
Yeah.
In that case, we do not need an ICD. We just need to take care of all the medication and everything so that the patient do not have similar episode.
Yeah, and then the polymorphic DT versus torsade, some people will say if there is a long QT and polymorphic VT, that truly is the torsade. But here it is polymorphic VT, no question. And you can calculate the prolonged QT, but it's most likely haloperidol induced, which compounded the problem with hypomagnesemia. So we don't need, the question is, in a polymorphic VT, they always ask, should we look for ischemia? Should we look for ischemia in this patient? My first year fellow was asking me in the round, should we look for ischemia?
No, it is clearly precipitated by the prolonged QT interval and RNT phenomenon. We could see that on the first rhythm history.
Yeah. And then arguably, if there was no, say that there is no haloperidol involved here, maybe magnesium, then should we proceed for a cath? So I told the fellow that, look, there is a subdural hematoma. So you need to be careful about doing cath, because cath is not like a photography lab. So we need to think about the situation in totality. So something to remember. So I'll finish this, the last case. Looks like we waited, Rafique Bhai never showed up. 41-year-old with obstructive sleep apnea, obese, and this EKG. And then the EKG baseline, please see the EKG above. And then in the night, this happened. So the question is, should we put a AAI pacemaker, VVI pacemaker, DDD pacemaker, treat CPAP and no pacemaker, or put a pacemaker and also treat sleep apnea?
Sir, what was the time of this event?
In the night, during sleep.
During sleep happening, when it's probably sleep apnea.
What I was asking? I was asking them, when did the next QRS came back, guys?
Dr.
Okay, so that is good, very good. But I'm still not happy that not a lot of people are opting for the vote. But it's good, 74%. Anyone comment, Atahar Bhai?
Yes, I'm agreed with the answer. That is the CPAP treat sleep apnea first. If this type of ECG persists, even after treating the obstructive sleep apnea, then we think about the pacemaker, not before that. So we have to treat the sleep apnea first. We have to correct the sleep apnea first. Then we have to think about the nighttime bradycardia or the long pause. Otherwise, not.
So I was challenged with this question, and actually I had to look into the Heart Rhythm Society guidelines. And because my question to you, maybe I asked you the question that in the round that in the team asked me. So when you are, how many seconds you wait before you put the pacemaker?
$1 million
in sleep apnea. Or you will never put a sleep. It doesn't matter how many seconds pause.
Did the patient fill this gap? Was he awakened or it was passed unnoticed?
No, the patient was sleeping and they're snoring. Okay. And the nurse reported that by the time nurse came in, the patient was still sleeping, because there was a panic call to the nursing station from the tele that the patient is asystole. And then they went there and they said that patient is sleeping, pulse ox good. And the nurse did not wake up the patient. So I don't know when, but in the guidelines, it says, it doesn't say any
There's
time
no numbers.
period for yeah. So there's no number. So I don't know. I wanted to know from the EP, the Rafique Bhai said that it is nerve-wracking. In this case, it was 9 seconds, and the other one was 13-second pause. So, I mean, 9 seconds is way too long for me. And 13 seconds, I think the option was just to wait and watch that the QRS will one day come back. So I don't know, but it is true. Their answer is treat the sleep apnea. The guy is obese, and so, but I did make him walk. Of course, thyroid was good, no medications, and then did the chronotropic response. You look at the EKG, there is no conduction system abnormalities noted, no left bundle, right bundle, no PR prolongation. So all these basics we checked, and then send the patient home with follow-up and monitoring in this. And I was trying to stretch that vertigo, was it like a syncope? And he was positive. His wife was positive that he never passed out, never felt dizzy. And the vertigo was positional. But sometimes you try to find excuses to put a pacemaker if you see this kind of thing. But you'll be following up with your EP doc. So that's all I have.
Thank you. It's great.
So, Dr. Hafiz.
Yeah.
Actually, what is mentioned about the indication of pacemaker in sleep apnea in guidelines?
It guidelines, it says that in sleep apnea, treat the sleep apnea. And
Yes,
if
sir.
it is always in sleep, then there is no indication. And it
Yes,
does
sir.
not say how long you need to wait. Now, if you see chronotropic incompetence or any other excuses or daytime, and then there is some other issues, daytime somnolence, and the patient is a machine operator, goes into pauses, you bring up those issues. And certainly you bring up these issues where if the patient is a airlines pilot or something. So one of my EP guys, he's actually in the board for the airlines pilot evaluation. So I actually send this guy to him because he will probably, this guy, patient is not an airlines pilot, but he's like a sedentary, what they call is the enterprise rental car, official clerk. So that's all I have, otherwise.
Thank you.
Thank you. Those are beautiful cases.
Arun Maski.
Arun, your comment, please. Arun, your
Arun
comment,
Maski,
please.
comment about the last case. Arun Maski, last case.
I cannot come in. I just joined because my net is lost. I just joined. So what was the case? Sorry.
Long pause in sleep apnea.
I just joined in that. I could not say.
You
Okay,
missed.
thank you very much for your joining, Arun Maski.
The first part I saw because that patient had sleep apnea at night.
Actually,
So that would be night-induced pause. So after that, I lost connection. I missed all these discussions.
Actually, can you show me the last slide? Can you go on? I forgot.
Yes, sir. 1 second.
Show me the last.
Sir, ekdom jeta last is, sir. This one, sir?
Okay. Yeah, show me this one. So, Dr. Maski, the issue was the sleep apnea and pause.
Yeah.
And we are discussing that in sleep apnea, just treat the sleep apnea. If the pauses are in the night during the sleep. So
And
there's no
this is not
indication
the,
of
this is not the ECG.
Okay.
Is this
So
the
this,
ECG? This
the
is
last
something
case.
different.
Last case.
so this is my last case. Sorry, I would be doing injustice if I don't show this, because this is just from this morning, and the fellow just gave me this and said that you can show this one, because the fellow was little confused, but he got it right though. 41-year-old, 2 weeks with COVID in our hospital. And then this morning, the ICU team called the fellow just before I walked in. So can you look at the EKG clearly? So this is the EKG, and this was the question by the ICU team to us. Is it a sustained VT? And is it a sustained VT with STEMI? Is it a sinus tach with STEMI? Or is it just sinus tach? And I added my option that, hey, I was not on call.
Do you want vote or you just one discussion, Habis?
Whatever you want, because we are running out of time.
So should I start the poll?
Okay, good.
Why
Go
not?
for poll.
Going for poll, sir.
I think we do for 1.5 hours. We are still within time. So the ICU attending wanted a STEMI activation, but the ICU fellow stopped the STEMI activation, says that I know the fellow, let me call the fellow first before we call STEMI activation. So majority said sinus tachycardia and then STEMI activation. What is the reason for STEMI activation? Anybody agreeing with that?
People are actually looking at the ST elevation in the inferior leads and thinking that this could be ST elevated MI inferior.
So, you know, we are writing this up about EKG reading in COVID time. It is very important. And particularly look at this guy, 41-year-old obese, 2 weeks with COVID in the hospital on vent, suddenly getting sinus tach, and then ST changes. But I have no idea how they reproduce this EKG with this kind of appearance. Looks like VT from distance, but it is not. And this is not even wide complex tach. This is narrow complex tach.
Narrow complex tach.
It's sinus tach. So I told them not to do a STEMI activation. It's just sinus tach. There is little J-point type ST segment changes in inferior lead, but it is to me not good enough, not enough to call for a STEMI. And to convince the team, we need to look at, you know, hypoxia, lactate going up or not. And then also we did a bedside echo. Echo showed normal LV function, and RV is little dilated, but RV is okay. But the patient is still hypoxic and struggling. So we did not. And then the two troponins, both are below 100, which is below 0.1. So we are good.
Can I make
So
a comment? Can I make a comment? Actually, the lead 1 and the precordial lead starting from V1 to V6 are not consistent with the QRS morphology in the inferior leads, that is 2, 3 AVA. Does this patient have the repeat ECG? Actually, metabolic cause is unlikely, as because such type of clean cut sinus rhythm in lead 1 and V4, V5, V6. And on the other hand, wide QRS complexes in the inferior lead in such a manner is, I think it is not consistent with the normal ECG. Was there any technical or mechanical error? Does this patient has got the repeat ECG?
Yes, a couple of things. You are absolutely right. We did not think about electrolytes, and the patient was hypoxic despite this fever also, still fever. And that fever is like low-grade fever. And he's also, and when I learned this, I was like, are you out of your mind? Patient is on 3 pressors, levofed and vasopressin, and also on epi. So, and patient is getting treated for sepsis. And I don't know how they created this EKG, but with the position changed and all that, the EKG, let me see. Can you look at the, show this second page? Next, I don't know, they added the, I know you'll be asking me the question. I got a clean EKG, maybe not. Maybe not. But that EKG was right. That there was no that artifact. But it is, I don't know, you call it artifact, but there is that ST little upturn in the inferior lead. But you see the white part, that white part we did not see in the clean EKG. But it is interesting, but I think in COVID time, it is important to evaluate the patient rather than just going by the EKG only and look at that.
This is actually a mechanical aberration, is it, or electrical aberration? This is ECG.
Say that again. Say that again.
Is it due to, is it electrical aberration?
Yes, actually.
Because
I
if you
don't
look
know.
at the ECG, the ST elevation is similarly elevated in inferior leads, also in AVL, but not in lead 1. Very inconsistent.
Yes, yes, you're right. This was
It doesn't follow any arterial territory.
Okay, so I show you, it is looks like something happening electrical, because let me see whether I can take my camera and show you the EKG. 1 second. Show you, I have the EKG, but it is not in the slide. Can you see the EKG?
Yeah, we can see.
Yes.
Okay.
So that there is inferior
Now we see
upturn.
more, and now we see also anterolateral.
Yes.
Yes.
Yes. But you see the precordial? This is the last one. But the white QRS type is gone. So, and I think this is all most likely, I think it is pericarditis. And if you look at the AVR, look at that AVR. So, and then these patients, troponin negative, but the D dimer, CRP is really high. So D dimer was, in the first 7 days, they did 3 D dimers, was like, 7.7 something. Now it is 16,000. So D dimer high. So I'm telling them this is a late COVID surge, and it is now giving pericarditis. It may be it may evolve into perimyocarditis. And I'm actually arguing for tocilizumab for this patient. But I'll have to go talk to my ID. We just saw this patient this morning. So, thank you. But this is not a STEMI. You all agree that this is not a STEMI.
This is not
I'm not going to take to the cath lab. And by the way, this patient going to the cath lab, not a big deal. It's more than 2 weeks. So according to CDC, he is not infective anymore. But we will still do the precautions, but it is not an infective patient.
Very interesting cases today. Atahar bhai, your comment, please.
Yes, we are at the end of our today's session. Actually, very extraordinary presentation, very academic ECGs, and very brilliant presentation by Dr. Chowdhury Hassan. He's always brilliant in his presentation, and we always enjoy his presentation. Very excellent ECGs. And I want to thank Dr. Azul Haq for your active participation in discussion, and Arun Maski, Dr. Swadesh Chakraborty, and all the panelists present here. I also like to thank everybody for their academic presence and their participation. And finally, Dr. Abdul Al-Jamil also. And I want to extend my thanks again to Chowdhury Hassan for your very, very, very brilliant and excellent presentation. There is an announcement. In the next Sunday, there will be a 50th lecture of our ECG study group. We want to celebrate the day. There will be a student and a teacher on that day as a presenter. Student will be our Dr. Sudhir Shah, and teacher will be our brilliant teacher, very popular teacher, academic teacher, Dr. Abdul Wadud Chowdhury. Next Sunday, student and teacher will present their cases. Dear participant, I request to present in that days. Next Sunday. And finally, I want to thank everybody, and Dr. Chowdhury, you can conclude and wrap up the sessions.
Arun, do you want to have a comment, please?
Oh, I mean, I joined in first half. Second half, I could not join because net problem. So I missed second half. So, I mean, looking at his presentation, this was a brilliant presentation. What I think everybody is looking is a clinical case scenario, what we face every day. So these are very interesting cases. Thank you, Professor Hafiz, for your nice presentations. So I have one personal request. Are we writing ECG of last patient? Hafiz bhai?
What's that?
Can I send you that ECG to you?
Yeah, sure.
So I'll be sending one more interesting case of locked-in syndrome. Yeah. That I presented in IPDI. That maybe if you review that, that would also be, I think, would be a first case.
Absolutely.
So both. Sure.
Absolutely.
Thank you.
Ajit bhai, do you want to have a comment?
No, it's definitely it's very nice ECGs, and that promotes our thoughts to think about. And interesting enough, the last ECG that we were discussing, initially looked like, the question about the questions put in very rightly, whether it's VT, whether some ST elevation MI going on, or just sinus tachycardia with some ECG changes. But the main provoking things that this ECG tells us that definitely the distribution of the ST elevation, there are some changes on the repolarization thing on the inferior leads that we saw on that ECG. Then it kind of progressed to anterolateral leads. I think Dr. Hafiz wanted to show us the AVR. I could not see that well, but there's really ST elevation there or not, or PR depression. Then then we could think of more pericarditis type picture. That was not very clear to me, but if we saw that, then we take his words, there's probably pericarditis. And nothing that ECG, look at that, the way
we are not done yet with this patient.
Oh, okay.
We are not done it. Because
okay.
Who knows?
Right.
But I'm just telling you that this is where we are. COVID is a challenge.
And another comment I'd like to make, definitely I didn't think that, but sometimes at the very rhythm strip, you see that when the QRS complex is narrow, it is narrow, so it's not VT, it's wide, and in between the R wave, that the distribution, sometimes it looked like initially whether it's bidirectional tachycardia or not, but it is not, definitely not. When you looked at carefully, it is narrow complex, is definitely not bidirectional tachycardia. But the main focus was ST elevation in inferior leads. That still I don't have clear-cut answer yet. What happened to him, because normally if it's a diffuse ischemia with COVID, we see diffuse changes, not in one distribution. Yes. Unless the patient has significant disease there, not significant enough, but with the vasopressors and all these things becoming ischemic in that area, transient ischemia, and that could cause that ST changes. We don't know yet, but it persisted on repeat ECG. So it suggests it's kind of persistent problem. At least 15, 20 minutes later, they repeated the EKG, I believe. So it's not like transient problem. So I wish I could see more ECGs on this patient and see what direction he goes. Okay. But the one good thing that is troponins are negative, so he definitely did not have event. That's a good point there. Okay.
Yeah. And also the LV systolic function is normal.
It's normal.
So,
yeah.
Yeah.
Mm-hmm.
Yeah. Okay.
Because sometimes we see like diffuse ischemia with multiple pressors, but why it would be initially in one distribution artery inferior is still not clear unless he has some borderline disease there.
Yes.
But we know in the COVID time with acidosis and hypoxia, this sometimes we are fooled in the presence of these pressors. And
I agree
we
with that.
sometimes get,
Athar Bhai, do you want to finalize it? Put the final comment.
Dr. Jamil?
Sir, nothing to say much about today's session. Hafiz Bhai always brilliant, and I always learn new things from him. I was a learner, so I learned a lot. Thank you very much.
Okay, I want to thank everybody for their presence and participation. And now we can conclude the session today. Okay, thanks everybody for your participation.
thank you everyone. So we dropped from over 90 to 45. So I think it is time to go.
Thank you.
Thank
Thank you,
you.
sir. We are
Good night,
concluding this
everybody.
session.
And
Thank you, sir.
Good
we'll
night.
meet again in a week's time.
Assalamu alaikum.
Thank you.
Assalamu alaikum, sir.